68-year-old female who actually presented with angina class 3 SAQ of 41 with risk factors completely controlled. So CKD stage 3 insulin dependent diabetic. EF was normal and stress test showed moderate severe ischemia in anterolateral everywhere, was on good medical therapy. So she had a cath just few days back, and you can see that she had a disease of the distal left main. And very important, we'll show you the angiogram. So only the left main with a syntax score of 18.
Okay.
So if you can see the angiogram there,
we need
yes.
the angio, please. Okay, nice trifurcation.
Yeah, so distal left main involving, is it involving angiographically, LAD, circumflex, and the ramus?
It's what it looks like, but let's see what Dr. Colombo thinks, because he's got all kinds of
It's a good
ideas
case for
for this.
provisional, no question. Is the Medina 111 the trifurcation, but very focal lesions.
So you would do provisional.
You need a 7 French guide because you want to do a final inflation with 3 balloons.
Okay, so that's probably not what Dr. Kinney is going to do, I promise you. Okay, Nitin, what are you going to do?
I agree, provisional. I mean, the burden of disease in the circumflex, and it's moderate.
So you would only stent, you would
left
stent,
left main into LAD. And I
where
do a
would you stent?
Cutting balloon.
Into the LAD and balloon the other 2 branches?
Correct.
Okay. Dr. La Sala.
I learned my lesson after the last one. I'm going to wait and see what the ultrasound shows.
Okay.
But I think I would be heading, usually is when you have a trifurcation is at the very, very least, you're trying to get it down to, 2 out of the 3. And
Yeah, that's what I'm thinking.
The least burden you're going to leave alone. You may not even wire it. But I would want to see a little bit more information as to what's at the ostium of the
Okay,
circ.
well, let's go to Dr. Sutton.
Yeah, I agree. At the ostium of the circumflex, it's a pretty short
What's happening to
lesion,
the
so
pressure?
A provisional to me would be pretty reasonable in this situation.
Sure, sir.
Okay.
Yeah, I'd say the same, except I'm interested if on the IVUS, there's not really that much disease in the osteal LAD. It's a little ambiguous to me too, and then the angles are really easy
So
to
you
recross
really
and
want to
blow
image
out.
this, which is, I'll go to Greg, and that's what he'll say. He's not going to tell you anything until he images it, yeah?
Yeah,
Greg?
of course I'm going to image it, but I'm definitely going to stand into the LAD, and I totally agree with Antonio here. I do a cutting balloon into the circ. I would do 3 wires. Maybe you don't have to treat the ramus, but I certainly would protect it because it's very large.
All right. Dr. Kinney, what's your plan?
So we will image, so we have the imaging both the left main to LAD as well as left main to circumflex, but without imaging, the question is what is called as a knuckle stent, that you just want to place a stent to the distal left main. So your 3 trifurcations, you do not touch at all. But once we image, let's see how else we can change it. That could we be able doing a provisional from left main to LAD, but definitely no 3 wires.
Okay, let's see. All right, let's have a look at your imaging.
Okay, so I'll start. This is a plug from the proximal LAD. I'll start like painting good area, big vessel, like follow vessel. Coming to the ostium. Yeah, now see that this is limus. Then the circ. And this left main has a focal 360 calcium. Body is patent. Very focal calcium. But it looks osteo LAD is patent.
Okay.
This is a plug from the LAD.
Well, are you going to go into the LAD and show us that the osteal LAD is? I don't want to just look at it.
That
from the
was
side
LAD.
window.
Yep. Now can I show you the
Now
circ?
we are going to the circumflex.
Yep.
Show
So
the circumflex.
this is the second plug from the
Okay.
circ. Yeah, like okay area. Some
Now very
calcium.
important, stay at the osteal circ.
Yeah. Now coming to the osteo circ. This is the LAD.
Yeah,
And the bifurcation.
and this is
Yeah.
left main.
So by IVUS, the osteo circ is patent. But the issue is that this is angulated circ. So this is tough to see the real osteo area because the plaque is a lot in the bifurcation part. So this is one of the limitations of the IVUS. What do you think, Dr. Kinney?
No, I think we'll be okay. I understand that we are not coaxial. That is why we are getting that eccentric cut of the IVUS. But I would still say that the osteal circ is okay. It's not to touch it.
Yeah, by IVUS, okay.
Yeah. right there. So after the imaging, what would be the plan?
Yeah, I agree. The osteocirc looks fine, so I'd put one stent into the left main, into the LAD, and with 3 wires just to protect everything, and provisional.
I think that's what Antonio wants, correct? Anyone have?
Cutting balloon?
From the beginning, you didn't need the IVUS to make this
Focal
decision.
calcium.
Oh, but you
But
are
I thought there was
always.
going to be
Oh,
some
come on.
osteocirc there. I thought there would be osteocirc disease, and the IVUS clearly showed there was
Yeah,
not osteocirc
exactly. That's
disease.
really
So I
important.
think the IVUS was really helpful.
Even if there is some osteocirc disease,
We can open the
you're
balloon.
gonna see after kissing dilatation, maybe after kissing, you get a good result and you leave it.
Okay, let's go to the sensible women on this plan. No, I'm joking. Let's go. Let's ask Kate. How does this imaging change, or does it maneuver anything about your plan?
I think it encourages the initial strategy. If there had been more disease in the osteocirc, I honestly would have just stented into that because I think the LED looks pretty good too, and you've got good bailout strategies.
So you are still provisional is your way. So everyone here is provisional. No one would be putting 2 stents and protecting 2. But what about Dr. Kinney's
375
idea of just stenting the distal left main without going into any of these branches? That's kind of a heroic effort. What do you think?
But this patient will not be enrolled in
Any trial, yeah,
stent trial.
yeah.
Because the stenosis is less than 5 millimeters or even less than 10. So this is clearly provision.
Press the button, otherwise
Beginning.
nobody could hear you. Okay,
You don't need IVUS to know that it's provision.
okay. Well, we need IVUS when we treat left main, so please understand that.
You need the IVUS for other reasons, not to make this decision.
Okay, excellent. All right, so Dr. Kinney, you're the operator. Tell us what you want to do.
Now, so if you go back to the left main, there is 3 millimeters short rim of calcium. Okay.
Yep.
Anybody thinking of IVL here? Or you think we
Yes.
can just do cutting balloon and proceed?
Yeah.
Devori wants to do IVL.
back.
Anyone else want to do anything
Go
or
back
just cutting
and show
balloon?
exactly where the calcium is. Yeah, right here.
Yeah, this is a distal left main 360, but the longitudinal length is just 3 millimeters.
Yeah, I know.
Yeah.
It's 3 millimeter. I know the arc is more than 180, but the length is not depth. I mean, we cannot say. So that's a decision we need to make. We have
Very-
both ready,
very
cutting
short
balloon
focal
versus
lesion,
IVL.
You don't need.
But
You
what
don't
about
need
cutting
IVL.
balloon?
Technically,
We have
you
we
don't-
have a cutting balloon, 375 cutter.
I
We are
don't
going
care,
in
but
as
you
we
don't need
speak.
it.
Anyone would choose any ablative technique here or just go straight with stenting or ballooning?
Well, you have to do
Yeah.
lesion preparation.
Yeah.
You can't direct stent it. You've got to make sure it opens up. But I must say, for
You
all
know
this
what? There's a
calcium,
lot
I
of
really like
crisscross. You see
OCT
that?
as opposed to IVUS, as you were saying before, because you really see the depth of the calcium.
So there was a lot of crisscross. If you had seen, my cutting balloon
Yeah.
was not advancing. So I removed the LED wire and recrossed it. Yeah. Okay. Let's go up here.
What size cutting
And then we
balloon?
will take a 4.0. This is a 375. I think
And
it opened up
it
well.
Nicely
Good.
open.
Yeah.
Go up here. So we will put a 4.0 and left main. What's the diameter, Kiski?
EVL is 5.0, but the lumen is, I think
I think
4.5
we go
is,
with a 4.5
yeah, is enough to
and
oppose.
then we can, post.
So what's your plan, Dr. Kinney? You're going to go into the LAD with your stents?
Yeah, we'll take a 4.5, go into the LED, few struts into the LED because everything is normal. And then we will do the proximal optimization into the left main.
Okay. So not a long stent, but a short stent with just a few struts into the LAD. Is that your plan?
Yes. Yeah. 4.5, what length you have?
12.
12? Okay.
It seems to me that the majority on this panel would like you to just take a longer stent and go just across that LAD, but
Okay.
you're not going to do that. But
Then we
let's
have
see.
to go 4.0. Or give me the diameter of the LED.
Yeah, yeah, like average EEL is 4.0.
4.0.
Mhm.
No, but you don't need a 18. 4 or 18. Yeah. So we can go 18.
Okay.
And then get a 4, 5 or 8 millimeter balloon ready.
Just a quick question for the panel. These last two cases, nice left main cases, are these routine PCIs at your institutions? Do you need to have a heart team to discuss this? Are your surgeons going to say this is left main disease, has to have surgery?
Yes, we need heart team discussion, at least where I am.
We probably did a heart team discussion here too, Greg. I can tell you that that happens
No.
at our institution. It's not a direct.
So ostial left main, distal left main with the syntax that is this low usually will not get a heart team. When you have left main, 3 vessel disease, high syntax, usually more than 23, intermediate more, 32 and more, that's the one that will have heart team discussion. Now, there was a lot of discussion, why not do DK crush, right? So DK crush 5, if you see how they took the operators, everybody had to have done 25 to 30 procedures of left main. And then what happened is, once they did the DK crush technique, the operators who were the PIs had to look at it and approve. That's the way to do this technique. And it's never been tested out of China. But I know everybody loves it. Everybody talks. But steps are a lot. Ready?
Yeah. Outside.
Okay, good. Go up. Yeah.
Roxana,
I'm going to
quick
do
point
this.
here.
Yep, go ahead.
You know, I sort of partially agree with Antonio, may not have had IVUS that circ.
No.
But if you're IVUS beforehand, you'll see the circ.
Yeah.
Even if when you're going down the LED, you get a side view of the circ and you can tell if there's anything there with the ostium.
Yep.
And I think it is reassuring, particularly for operators that are not as facile and who don't do a lot of these, to reassure yourself there isn't much
Imaging
there
really
that you need to
helps,
worry
I
about.
think.
4, 5, 8.
Take a picture.
And then, okay, take a picture. We'll do a quick 4, 5, 8, and then we will IVUS. So everybody is happy with it. Ready?
Yeah.
Looks
Very
good.
nice.
Yeah.
Very
All the
good.
branches are patent.
Right.
So will you do a little bit of touch up of the osteal circ or not?
No recross and kiss. Actually, myself and Greg published that from Excel trial. Greg, you want to discuss that paper that we said? Kiss versus no kiss after left main stenting?
Yeah, interestingly, you know, from Excel, it didn't seem to make a difference. And
I would
Dr.
like
Kinney was the
to-
first
The
author on
largest
that.
randomized trial,
Now,
yeah.
of course,
Go.
that's not randomized, so it was,
Yeah, I feel like-
I mean,
but-
bypass was not
It's a little bit
randomized for
against
technique.
your-
Right, but remember,
thinking.
we did use, you know, IVUS in, you know, about 82% of the cases. And so if you do show with IVUS that the lumens are good, then there's probably, you don't have to do a kiss.
Go up here.
Mm-hmm.
Good.
Came back.
Good. I came back a little bit.
But, you know,
Okay.
right now, what I'm thinking about is recrossing that circ and just, if there
No.
is some, and just giving a little bit of a balloon dilatation there at the crossing
There
of
was
the
no
circ.
plaque
Good.
there.
Let's do the
Yeah,
IVUS.
but
Yep.
you take a look now. Well, they'll have to give
But you
some,
can get a
We'll
pseudo
do the IVUS
because
now.
of either some
Yeah.
Save the
spasm or
dye.
angle, but there wasn't
Spasm.
plaque there, so unless it looks
unless plaque
really
shifted
bad.
in or something.
LED. Same
Maybe
size.
not. Let's see what we got. Is that IVUS?
Yes.
This isn't really evidence-based, but, you know, in a young patient, if it's a large circ, or if there's any moderate downstream disease that was left alone, I'll pretty routinely open the stent struts, not for the acute result, but just.
Okay.
I think even within our own center, there are variation of how to do this case. Yeah.
Okay, it's a native. Okay,
going
start
to
way
start.
back.
Yes.
Some disease part. Eccentric plaque, native. Yeah. Landing zone is perfect. Great area.
Oh, I'm sorry. Dr. Waxman has a comment.
No, I heard a lot about DK Crush, so I tell you why I don't like DK Crush, so don't feel guilt. It's a lot of steps, but I don't care about the steps. You have no idea
Yeah,
how many
stenting.
wrist stenosis we're
Perfect.
getting with DK crush. A lot of them. So maybe in China there is a magic, they know how to do it, but we get a lot of cases for brachytherapy, wrist stenosis on both arms, not only circumflex, also LAD.
Ready?
So don't
I'm going
push
to
me
take
to
out
do
the- show
DK
some
crush.
dye. I'll take
The
the second
second
one
thing, I remember you doing a case with S.J. Park on left main many years ago,
Yeah.
you,
Ready?
Me,
in
yeah.
Korea, and he used to compromise all the circumflex. No one
All the
cares. He
time.
did one stand, and he got very good outcome with it because we know the surgeon is most likely
Okay,
not
move the
even
camera
going
a
to
little bit.
revascularize
Move the
that. So I
sources,
don't
yes.
think we have to push, and
It's so
that's why I'm not
great.
surprised
Okay.
with the paper that Kinney and Stone published, because I don't
Ready?
think that we have to, once you have instant wrist stenosis in the osteal circ, it's really bad disease. So you probably not have to rush to stent it.
No, this looks good.
I
now.
totally agree. I think you have to do all your best not to stent the circumflex.
But this looks beautiful. Look at that, the ostium.
Doesn't look beautiful.
Yeah. All right. Well, it looks really good. Bravo. Very, very nice case. Thank you, Dr. Kinney.